Because of the position of the head and neck in cervical dystonia, secondary problems could arise as well. We need to use good judgment in assessing the patient, but if the patient is able to tolerate additional exam components, and we feel that it could be beneficial in setting up a more comprehensive treatment plan, we can look at a few items often assessed in a general movement examination. Active and passive range of motion is a useful assessment to determine the state of the muscle function and joint function during movement. It gives us insight into length-tension relationships of the muscle, how guarded a patient might be, soft tissue tension, and joint mechanics. Strength testing can have some value because of the inevitable weakness in some of the muscles that aren't being used in dystonic postures. Restoring strength to some of these can be beneficial for stability of the head and neck and can help decrease pain. Joints can become stiff, so a joint mobility assessment can be beneficial to determine if the areas need to be treated with certain hands-on techniques that improve the mobility of the joints in the cervical or thoracic spine. Neural tension can also be tested. The postures and positions in cervical dystonia can impact the connective tissue that surrounds the nerves in the neck, shoulder, and upper arm area. If it's tight, it can be painful, which will lead us to treat this impairment. Palpation and soft tissue assessments can give us insight into the state of the soft tissues. Are they contracted, or is there excessive tone? Or does the soft tissue move freely? Lastly, we can pick a particular movement and analyze how it's being performed. If, for example, getting up from bed was inefficient and difficult for a patient, we can analyze the movement and determine where the inefficiencies are. If we make the movement more efficient, maybe it could help manage the cervical dystonia in some way. Or maybe we can discover a sensory trick along the way that decreases tone, or introduce variability to the somatosensory areas of the brain and tap into neuroplasticity that can facilitate efficient and specific sensory integration. Or perhaps the decrease in the effort to move helps the patient in some other way. It just requires less energy. By performing a thorough eval, we can chip away at the impairments or limitations and improve the patient's condition. So now that you have an idea about sensory integration and the other musculoskeletal impairments, we can try to make a big impact on the patient's function right away. Can we find something during their first visit that they can take home with them that will improve function or decrease pain, i.e. an immediate response? Immediate responses might be hard to come by, but many patients have discovered sensory tricks, which are movements they have learned or discovered that can instantly calm down the muscles. It can be a number of things, so note the table there that I included. More examples include ice on the neck, the chin tuck, therapeutic taping, or electrical stimulation. Even yawning can help. Unfortunately, the effectiveness of these sensory tricks can diminish over time, so hopefully we can give them a number of sensory tricks to manage their impairments. A good goal to keep in mind when addressing the sensory tricks is to gravitate towards movements that can be incorporated more easily into functional movement pattern. For example, a chin tuck, or putting your finger on your chin, could have carryover into more functional movements like brushing the teeth, combing the hair, eating, compared to other sensory tricks. They're all good if they decrease the tone, but if we can have like a sliding scale from optimal to less optimal, something like that would be more optimal. Could be more optimal. So moving on to treatment, learning-based sensory motor training is an approach rooted in the idea that we can tap into the neuroplasticity of the brain to affect change. Neuroplasticity is when brain activity associated with a given function can be transferred to a different location in the brain. There are several parts to this. One would be preparing the patient. 2 is the sensory motor treatment. 3, treating the underlying factors. Preparing the patient simply means that we're setting the patient up for success by preparing the brain to tap into that neuroplasticity and decreasing the symptoms that impair movement function. Some concepts are quieting the nervous system with breathing and positioning, imagining normal movements as a mental warm-up, a visual exercise, enhancing expectations involves motivation, and autonomy involves patient participation in the decision-making process. Quieting the nervous system aims to decrease the tone in the cervical spine musculature. Our ability to facilitate this should enhance our outcomes. We're in a unique position to facilitate this because we spend several days a week with the patient over several weeks, allowing us to explore the full potential of this intervention. This can be done several ways. Diaphragmatic breathing exercises can help. A deep inhalation followed by a prolonged exhalation can occasionally result in an immediate response. Proprioception and positions can be used to enhance the breathing component and other aspects of treatment. A stable base is essential. Once you're in a comfortable position, we want to instruct the patient to feel the quality of their position. They can scan their body from top to bottom, feel where it is in contact with the surface you're on. It's great with dystonia because of the sensory issues that we discussed earlier. A safe movement with breathing means that we will help them move in a functional manner, pain-free while working on their breathing techniques. Enhancing expectations involves your ability to motivate the patients and applaud their efforts. Autonomy involves giving the patient choices. They can choose things like how many repetitions they want to perform or what exercises they want to perform. Autonomy has been found to improve outcomes compared to like a less autonomous setting. The sensory motor aspect of the treatment is important because it is considered the root cause of the problem. We want to shut down abnormal movement. You can do this with the sensory tricks we discussed earlier, or with different activities that change the sensory experience in different areas, such as retraining movement and inhibiting bad movement. For example, with head positioning accuracy, we can do things to increase the chances of success and retrain the brain. We may find that moving the chair or bolstering the body increases the chance for success and inhibits abnormal responses, allowing for a greater chance to progress the patient. Another example could be to use a yoga block for the head so you can push into it for feedback. The idea behind this is that the muscles that could reverse the dystonic posture haven't been worked in a while, and pushing the head into the yoga block in that direction could wake them up a little bit and provide a new sensory experience that the brain so desperately needs. Also, in activating those muscles, it could decrease the intensity of the dystonic muscles a little bit, just kind of working those contralateral or antagonist muscles. Breaking down a functional task into parts can help with sensory motor integration and skill acquisition. And finally, a ton of repetitions are needed. Lots of practice is required, 10 to 100 reps a day, depending on the activity. So daily activity to achieve those neuroplastic results. Many other things can be done as well from a sensory motor perspective. For example, light touch with a cotton ball. Touch a body part most commonly affected by cervical dystonia with a cotton ball and ask the patient to identify it. Can they pick up where that cotton ball is touching? This activity can be modified by touching a body part and asking the patient to identify the body part from a display sheet full of body part images. TENS is a type of electrical stimulation that can be used to provide variability in the sensory feedback we are getting. Proprioception with the fingers, hand, arms, shoulders, or neck can be performed as well. And graded motor imagery. Graded motor imagery is another intervention for pain and movement disorders. Graded motor imagery enhances the somatosensory functioning in the brain, which can help decrease pain and improve mobility. Neuroplasticity is the mechanism by which this occurs. It does this 3 ways. It challenges left-right discrimination and uses motor imagery and mirror therapy to enhance neuroplasticity. Left-right discrimination is the process of identifying one side of the body as distinct from the other. Basically, can you identify the right side from the left side? This can be quite impaired in people with dystonia and in those with chronic pain. For example, when viewing pictures of body parts, they are slower and or less accurate at determining whether the image is a left body part or right body part than somebody without pain. This ability appears to be incredibly important for normal recovery for pain. Explicit motor imagery is thinking about moving without actually moving. Imagined movements can actually be hard if you're in pain. By imagining movements, you use similar brain areas as you would when you're actually moving. This is why athletes imagine an activity before they do it. This is why you can feel exhausted after watching an action movie. It's exercising the body before, it's exercising the brain before the rest of the body. There are many ways to go through this process. For example, imagine that you get into a car and drive to a destination. Think of the road you'll take, what signs you'll need to read, and route to your destination. Think about rotating the head from side to side as you look at signs or look at a familiar building or prepare to turn. It can be progressed by increasing the complexity of the imagery or incorporating environmental cues like sounds, memories, smells, temperature, breezes, etc. You can play music, and you can practice this anywhere in any position. The last stage of graded motor imagery is mirror therapy. Just like most of the things we discussed today, the mirror box trains the somatosensory piece of function. If you put your left hand behind the mirror and your right hand in front, like the picture, you can trick your brain into believing that the reflection of your right hand in the mirror is your left. You're now exercising the left hand in the brain, particularly if you start to move your right hand. Start with exercises involving little or no movement. Just watch your unaffected hand. Gradually increase the difficulty of the exercises in front and behind the mirror. We discussed finger proprioception being impaired in patients with cervical dystonia a few slides ago. So the hand is clearly an area that we may need to address. Not in everyone, but in some. So this is a way to restore function and optimal movement of the hand. Depending on the pain or level of impairment, decide on an appropriate activity to perform with the good hand. This could range from just looking at the mirror image to finger movements or putting weight through your hand. In general, the more severe the problem, small movements performed often will be more appropriate. You should feel comfortable with the selected movements before progressing to a more challenging movement. Once you feel comfortable with a movement, try and perform it in a different context. For example, do it while solving a math problem or change the time of day you typically do it. Overall, you'll need to repeat the movements, grade the movements from easy to more difficult, and then enrich the movement with different contexts. If the hand in the box hurts or sweats, take a break and try something a little less challenging next time. If you have hand pain, you can move the painful hand in the box to the point where it starts to hurt just a little bit. But move the good hand, which is outside the box, a bit further. So like maybe making a loose fist in the box and making a full fist with the right hand outside of the box. Of course, if there's a mechanical blockage in your left hand, like you actually have some wrist issue or hand issue, that is completely different. But if it's just a sensory issue, if there's really no tissue damage in this hand behind the mirror, it should move, right? So if you're getting a different range of motion, there's a big discrepancy there, then the mirror box can help that with the sensory integration. The underlying factors are the things that would be considered secondary to the primary cause of the problem. For example, tight chest muscles don't cause the dystonia, but they can get tight and amplify the posture impairments seen in cervical dystonia. Joint mobility did not cause the dystonia, but because of the position of the neck, we may need to work on the joint mobility to decrease pain associated with the joint mobility problems. Even though these might be considered secondary, they're still quite important to address.